Good evening, everyone. Today, I'm going to host a session. My name is Dr. Natasha Juraratanaporn from Ramathipadi Hospital, Bangkok, Thailand. Today, we are very lucky to have two leading experts in the field of ultrasound in aesthetic dermatology today. We have the first speaker, Dr. Peter Weltus. Dr. Peter is a highly respected dermatologist with over 30 years of experience in clinical practice and also the founder and medical director of the Weltus Clinic. Through his company, Cutaneous, he advocates the use of ultrasound in cosmetic medicine. He is also the president of European Society of Cosmetic and Aesthetic Medicine, or ESCAD. The next speaker is Dr. Roya Sarmer Samin. Dr. Roya is a highly accomplished aesthetic physician, instructor, and clinical educator with up to 3 decades of experience. She is a recognized international speaker and also a key opinion leader of ultrasound trainer for Clarius. She provides worldwide training in ultrasound for aesthetic, covering subjects like ultrasound-guided procedures and application of ultrasound for safer practice. Our agenda today will be about how can Clarius ultrasound help your filler treatment safer with better outcomes and more profitable. Our agenda will be an hour lectures from our two speakers and followed by 20 minutes of Q&A. So please give me a warm welcome to Dr. Peter and Dr. Roya, and let's start our session today.
Hey, thank you very much. It's a pleasure to be here, a pleasure and an honor, I must say. Let's get me started with this. I hope you can see my screen right now.
Yes.
You can see it, right?
Yes, I can.
Okay.
Hope everyone can see it. Yeah.
Yeah, I think so. So again, I'm very honored to be here. I have been working on ultrasound for 11 years now, together with my colleague Leonie Schelke. And mainly at Erasmus University, we do a lot of research on this topic. And then, of course, we have our own practices in cosmetic dermatology, cosmetic filler practices, which makes it well easy to bring to practice what we have learned in the university. I'm not so much acquainted with the Clarius L20 until 1 month ago. And then I received a machine to work with, just to practice and see how it works out. And I always had the impression that it was like a lower end machine, but I must say I'm pretty much impressed with the new type of machine, mainly with the software, because it's been updated to a degree that, well, really is remarkable. We're going to speak about that later. Again, we're going to do 1 hour. A little bit more maybe, and well, I do like different sections on the different topics that are there. I will start with something very easy, but I will dive quite deep into what we've learned with ultrasound in general. So let's get started. This is my colleague Leonie Schelke. Together we formed this small company Cutaneous, which Dr. Roy is also a part of as a trainer. And we do mainly facial ultrasound. Some principles, very basic. How does ultrasound work and how to interpret what you're seeing? Isoegoic, hypoegoic, hyperegoic, and anegoic. Those are the basics, of course. People frequently ask me how to distinguish these isoegoic ones. Well, the thing is that, let me see. I'm trying to show you something. Yeah, let's go with this. So, for instance, you see something here because it has a different texture than the rest of the tissue. That's basically what isoegoic means. It's more or less, and that happens frequently actually with hyaluronic acid fillers at some time. Once they're there for 1 or 2 years, it might become more or less isoegoic. Okay, then I'll have to stop this again. Okay. Oh, I have to erase this. But anyway, so it started all like this. We have been doing this filler clinic for 11 years now. And at some point we said to each other, Leonie and myself, why don't we do more prevention? And that's what this is, right? You can scan before you do any injections where the arteries are, for instance, in the lips. If you want to go into the lips, you may scan to see where the artery is. And if it's not superficial, and well, you're bound to inject superficial, then you're okay, right? So let's get rid of this. I'm sorry. Yeah. Okay. Over the years, we've done many courses. We more or less found out that it's not so important to be able to name every muscle, every structure in the face, but mainly to identify the layers, because that's what injection of fillers is, right? You either inject superficial or you inject deep. So you need to know where those layers are. And basically there are 5 layers. It starts with dermis epidermis, and you can see it on the upper right image. Then subcutaneous fat, SC, which is also called the hypodermis or the superficial fat pad. That's all the same structures. Then it's the muscle, or it's the SMUS, and most of the muscles are being enveloped by fascia, which you could call the SMUS itself. So it's an extension of that. And then there is deep fat, and then there is bone, right? So those are the 5 layers being identified by Mendelssohn like 20 years ago. So here, if you look at the skin, then it's always very white on top, the epidermis, which contains no water, so it reflects a lot of image, so it's white. Then the dermis itself is less white, so it's hyperechoic, but less than the epidermis. And then the subcutaneous tissue. Well, you have to understand that subcutaneous fat is in fact black by itself, but it's lobulated. So there are like little packages of fat being surrounded with fibrous tissue, which is white. So the layer itself is black and white mingled. Now, muscles are black because they contain a lot of water. So the muscle that you can see here on the left side is the zygomatic major muscle, and it's not so fibrous. But the other one on the right side, the masseter muscle, is indeed contains a lot of septae, and by this you have a lot of white flat structures inside the muscle itself. So it depends on which muscle you're looking at, but mainly they are blackish. And the bone is white. It's the hyperechoic line at the bottom, and everything you see below this hyperechoic line is an artifact. So that's also important to know. Now, sometimes you see an interruption in the bone, as you can see here on the left side, and that is basically a foramen. And sometimes you see an artery coming through there, and well, you see some shadows under this foramen on the left side, and those are also artifacts, but those are helpful artifacts. They help you to identify this structure. Again, here the same foramen on both sides, and you see some what we call reverberation artifacts, and these artifacts they draw your attention, so then you know there's something to look at, and it helps you to find this infraorbital foramen. Okay. This is the forehead. Try to name for yourself the different layers. You see outside is black with the stars in it. That's the autopharyngel. But then it starts to count. And if you do it right, you see skin, subcutaneous fat, muscle, and there is some submuscular fat here and bone. Again, this is the temple, much more difficult because it contains many more layers. But I'll try to identify the layers. The outside is easy, right? The corneal layer, epidermis, dermis. But then comes the subcutaneous fat. And see how small this layer is. Then the different fascia. And of course, you know we frequently inject between those fascia. We will go over that later. Then there's a fat compartment. And then there is a fascia again, and then there's muscle. Actually, there is a little bit of, let me see if I can point this out with a laser pointer. There is a little bit of fat here coming in from the cheeks, the Bisha fat pad. This is underneath. So this looks a little bit blurry, and that's because it's not a muscle. Again, try to identify the layers, epidermis, dermis, and then underneath these layers, subcutaneous tissue, the parotid gland. Parotid glands, the mucus glands that deliver material inside the oral cavity. They are homogeneous and more or less hyperegoic, as the parotid gland. And we're going to look at the submandibular gland later on. And this is how it looks like. And this is the masseter muscle again. And now cut in a different direction, which makes it look different maybe, but you have to understand that it's there. Again, this is more in the mid-face area. This is the outside dermis, epidermis, and this is the bone and all those layers in between. I hope you recognize the fat pad here, the SMUS here, which is actually the zygomatic major muscle, and the deep fat. Okay. Now then, of course, the vessels, which are anegoic. And well, if you identify a vessel, you better rotate the transducer a little bit to see how elongated, and then you can follow it also in the correct direction. So you identify a vessel, you make it more elongated and then more linear, and then you try to follow it. That's the way we usually try to identify vessels. We always skew the box like this because you need to understand that this skewed box only picks up a signal when something comes towards or goes away from the probe. Now, if this artery or every vessel that's there is completely parallel to the skin surface, it doesn't pick up anything with the ultrasound. So then, when you skew artificially the direction of the ultrasound waves that come into this tissue, you will get a signal. Right, so this is what it is. So this is what you're doing when you put on the color box and you skew it a little bit. What you also need to understand is that you see sometimes more than one vessel, and this might be the same vessel. Actually, in this instance, it's not. This is the vein because we're compressing. As you can see, we lifting the tissue. That's because we compress. But you make a cut through the tissue, so it means that these two vessels are actually the same vessel, right? So they go in and out of your image. This is a beautiful longitudinal cut, longitudinal vessel here, but these are all the same vessel. Okay, so coming from static anatomy to functional filler anatomy, we wrote an article about this. Because you can also ask your patients to contract, and then you can see what's happening there. This is the zygomatic major muscle. You see the contraction of the muscle here. This is the muscle in the middle. It's a little bit fibrous in this image, but it tends to become shorter, but also thicker. And that's, of course, what muscles do. Now, a few words about the Clarius, which indeed I received 1 month ago. I've been going over it quite eagerly, and well, you might know me. Once I have something like that, I try to use it for everything that I can think of. And I think this is marvelous. This machine is quite good. It gives you a very good resolution on the superficial different superficial levels. One thing that I must mention is the focus points. Sometimes when you need something very superficial or very deep, you have to adjust the focus, which helps a lot, actually. And then there is this power Doppler, which I'm not so much inclined to use, but the Doppler function in this machine is very good. And I use it very much. So, and then there's the needle enhancement, which is also very helpful. Then, of course, there are some more advanced functions that I won't go over, but well, you need to know about them as well. Okay, so have a look here. This is let's have a look. what's happening here? Yeah, they have this aesthetic mode here, which is, this is for lips, and you can clearly identify the teeth, of course, and the muscle here, the auricularis oris muscle. And on the front page, so the one that you're scanning with, you can easily switch with aesthetics from one to another area of the face. And this is important because it adjusts the settings when you're doing this. And also in some of these areas, you can put on the T mode, which is very advanced type of artificial intelligence. And it has, I've seen it 1 year ago, I think, and it has improved tremendously. But still, there's a lot to be done, of course. But it's a very good way to teach yourself how you can work with this machine. Okay, now at some point let's go over the anatomy a little bit. At some point in time, we published about the standard positions, because when you start using ultrasound, we thought it might be helpful to have a position for each area to start with, because then you're going to see the same type of anatomy all the time, and it's going to be like something that you recognize. But because sometimes with cutaneous also we receive photographs from around the world, and we don't know what we're looking at, and you always have to have a reference point to know where you are with your ultrasound. So this is how it looks with the Clarius, this area, and you can see the parotid glands. We've seen it, the masseter muscle, the subcutaneous space, and the skin itself. And then when we move more caudal, it looks like this. You can clearly identify the SMAS here, or the masseteric fascia, as it's called in this area. So I must say I'm really impressed with the resolution of this machine. When you go a little bit further, more down, more caudal, you can see the edge of the masseter muscle, subcutaneous space, and then you're moving towards, this is the deep fat pads. This contains the arteries, as you can see here, and you're moving towards the pressure oncle oris. This is the vein, this one here. And you can see when you compress, like we're doing now, that it is a vein. So again, when you are like this, so more vertical, you can see the different septae and fascia in a more straight and longitudinal way. Whereas if you are like this, you see the same muscle, but it's much more like different small hyperechoic fascia. And then this is also a structure that is much forgotten, I think. This is the buccinator muscle. And at some point when you move upwards with your machine, you're losing the contact to bone, and then you are bound to see this muscle, which is below and in front or more medial to the masseter muscle, the buccinator. And this one ends here in the modiolus. You see a vessel here, yeah, right? Now the downside a little bit of the Clarius L20 is that you don't have a very broad image like the L15 had. But the advantage of this is then when you're using it for specific purposes, like for instance complications and ultrasound guided injections, it works much better because it's so small. You can get under it much easier, and you can identify much easier where the problem is. So again, I like the machine. So I've been talking for 15-20 minutes now. Roya, can I ask you, do you have anything to comment on this? Are you using the machine a lot just for anatomy, or what do you think?
Thank you so much for the presentation. It was amazing. Thank you, Peter. And thank you, everyone, for joining us. And thank you, Dr. Nazchat, for introduction. I'm using it every day, but I'm not saying every day for every single patient. I'm using it for all my training session for toxin and filler, because I want my colleague to see what depth I'm going to, place my product, and then check all the depth, all the thickness, and everything. Even for energy-based device, I use it to just precise the depth of this mass. For example, for HIFU, for all the skin rejuvenation treatment, either with injectable or non-injectable energy-based device, I'm using it as well, because it's so, it's very user-friendly, and we can have it in our pocket and use it, every day. But mostly, if I'm not in my training session and in the clinic, for every first-time patients, I'm using it to make sure, everything is beneath the skin is safe. I see the variation, I see the permanent filler, and also all the measurement that I needed. But for my, existing patients that, coming regularly, I'm not using it unless I'm going to inject in the risky area. That's why I do the safe mapping before. For example, the most common area that I'm using for safe mapping is the temple gunshot technique, and for preform fossa. These two, because the variation is a lot, and there is a chance of blindness. The complication is very, can be disastrous. That's why I'm using it. And the other time that I'm using it is for seeing my cannula beneath the skin.
Okay. May I stop you here, because then I continue. Thank you for this comment.
Yeah.
Actually, I do quite the same, because that's indeed what you're using it for vascularity, and for see if you have enough space for your injections. So that's exactly what I'm doing. So let me continue a little bit about the anatomy, and then we come to the vascularity. Many people.
Perfect.
So this is the depressor anguli oris, the DAO, this one, and then you see a black line underneath. You see another black line, which I think is the because this is medial, this is lateral. I think it's the buccinator, and this is the oral cavity. This is just in front of the mouth. And then when you go a little bit more medial, you see this foramen here, the mental foramen. Okay. Vascular mapping. Dr. Roya already alluded to that. These are the areas that I would not go in without mapping. Actually, I don't do much forehead or temple or glabella. I do temple a lot, tear trough. Well, that's always a difficult part. Okay, so let's go over these a little bit. This is the variation of the anatomy of the facial artery. You can see that this is actually the type 2 is actually the most frequently found one. But you should be careful with that, because after surgery, especially rhinoplasty, there may be a variation. There may be quite a number of variations down there, and especially the columellar artery, the one that's running here, and the angular artery may become either very prominent or absent, and other arteries take over them. Now, especially the piriform space, and this is a bit of a difficult picture maybe, but this is the bony part, and you see the blue part is the piriform space. Actually, I think I would say it extends a little bit down even. And these are the injections that you do. I love this. I do it in almost every patient, because you lift up the whole area here, and this is not so deep anymore without injecting the nasolabial fold. But there might be, and you can see here, more than 92%, it's more than 1 millimeter above the bone, but there might be in 3% an artery on the bone in the piriform space. And this is not Clarius, but this is colored by myself, actually. So this is the deep fat of the piriform space. And once you encounter a version like this, with an artery on top of the bone, I would advise not to inject there. And when on the other hand, the artery runs like this, and this is the space you're going to inject into, you're fine in terms of problems with the arteries. Change of the plane of the on the forehead, change of the plane of the supratrochlear and supraorbital arteries. We did some study about that, and as you can see, it is similar in male and female, and it comes from the deep fat and goes more superficial at about 1.4 centimeters. But there's a huge variation on this, and this is how it looks like. Here it's deep, and then at some point it becomes more superficial. Yes, on the forehead, this is the lateral part of the forehead. This is more medial. This is the frontalis muscle here. And this is vertical, so this is cranial, this is caudal, so this is close to the eye. And here you see the frontalis muscle. And what you may appreciate is that underneath the frontalis muscle, there is some space, which is called the roof, the retroauricularis oculi fat, but it's only close to the eye, like over here. When you're higher up, there's almost no space. It's like a virtual space, and if you want to go in there, you need anesthesia, local anesthesia, to open up this space. Very nice to see with the Clarius machine. Now these are the arteries. This is a vein actually. This is in the glabellar region. You can see it's a vein because it's so well. It's not really pulsating. And again, I love the duplex Doppler function of the Clarius. You can see it very, very well. Now, if you want to see the nose, you have to use a lot of ultrasound gel. That's one thing, and then you can see this. This is the bone again, and this is the muscle, the procerus muscle, and then it ends in the in something which is more cartilage, like over here. And have a look. This is the bone, so it ends here. This is the cartilage, and then you can see structures inside the nose because cartilage is does not block any of the waves, the ultrasound waves. So these are the congae. And then when you want to scan the nose, I always go horizontal because then you can see where the dorsal nasal artery is, which is on the side here. And I cannot detect one on the other side. So that's quite unorthodox, but that's the case. So if you go from down to up, so from caudal to cranial, you will recognize if there's anything in the middle, but which is the most important thing to know. So the dorsal nasal arteries are on both sides, as you can see here, but sometimes it crosses over here. There's always some cross on the in this radix area, but not so much on the middle of the nose. But it's very frightening when you see that. So here's the nose. So this is the caudal part, the cranial part, and here we see a vein, obviously in the radix, right? And this one is crossing over because this is exactly the middle. And then when you move a little bit to the side, you can see the dorsal nasal artery on the right side in this case. Okay, well, midface, you've seen this picture. There's this important structure, which is the muscle, the zygomatic major muscle, which divides the subcutaneous fat and the deep fat. And you can think of this zygomatic major muscle as the SMUS, as being the SMUS. This is very interesting. This is the tear trough. On this side, you can see that. This is close to the nose. This is more to the cheek. This is the area you're going to inject into if you're doing tear troughs. And you can see this very huge structure, which is the angular vein. And you can also see this structure here, which corresponds with this opening, which is the infraorbital foramen. So you can see it's like a minefield of arteries or vessels. And well, it's very difficult to get your material in without compromising one of those. And on the other hand, if you put in too much there, you might compress the vein. And we think this is a major cause of the malar edema. So if you're ever going to do that, and actually I'm still doing it, Don't put in too much, like 0.1, 0.2, and undercorrect. Don't ever try to correct it completely because you're blocking something. This is from another direction, the infraorbital foramen, which again, the helpful reverberation artifacts down there. This is again the piriform space with an artery well above that. Now for the temple, we've seen the different layers. Let's name the different structures. Skin, subcutaneous fat, superficial fat compartment. That's a very big misnomer because there is a superficial fat area here, but that's how it's called. And then the different fascia, the deep fascia and the superficial fascia. And then this is the deep fascia, the deep level, the deep lamina of the deep temporal fascia. So this fascia splits in two somewhere around here. And then there is muscle, then there is bone. And I pointed out already, this is a fat bed coming in from underneath the zygoma from the cheek, a deep fat bed in the cheek. Now, if you want to do some training on this, it's always very nice to try to find the superficial temporal artery, which is a very prominent, one of the two most prominent arteries in the face. The other one is the facial artery. And it's very close to the ear, actually. I don't think this image gives credit to that. It's more lateral than this. And as Dr. Roya said, there is also, with the gunshot technique, there is another artery here on the bone. And let's have a look at that one. Now, first, let's appreciate that this is the crest, so this is the forehead. If you ever want to go into the interfacial plane, you can see that there is a plane between those two fascia. This is the periosteum, which is continuous with the deep temporal fascia. And this is I think, the orbicularis oculi muscle, which is in fact continuous with the superficial temporal fascia. And if you put your cannula in between those two, so you come in here and you touch the bone and you proceed with your cannula in this direction, you're bound to be in this, well, more or less virtual space that's there, the interfacial plane. Again, the deep arteries in the temple, those are the ones here. You not want to compromise those. And those are exactly on the spot where you want to treat. So have a look here. This is a little video. So I hope you recognize the muscle here, the fat pad here. And this is more or less the space you want to inject with this gunshot method, right? So this is what we identify to be the exact spot of the gunshot method. And have a look here. So this is not the safe area for injection. You can understand that, right? Okay, so then you have to shift a little bit so you're not going to do it there again, but then you are going to do it a little bit like half a centimeter more lateral or so. Okay, so this is the upper lip, the modiolus again, extending to the orbicularis oris muscle. And what you're looking for here are the vessels. You've seen it in one of my previous slides. And again, here the vessel is not very superficial, so you're clear to inject in here. It usually goes in and out. It's like a snake dance. It goes underneath the muscle and then it pierces inside the muscle and then it goes out again. And but sometimes it's really superficial. This is a beautiful image made by Clarius. This is the upper lip, and it's vertical. It's like this. So you have a look at the longitudinal cut through the lips, and I hope you. So this is the upper lip. This is the lower lip. What you appreciate is that this is the muscle, and you don't see it so well here, but this is the muscle, and it is like a hockey stick. It goes like this. Right, so it has a pars marginalis, as it's called, which is this one, and a pars piriformis, which is this one. And this is the area you have to inject into. This is the dry mucosa here, and here is where the skin starts, more or less here or so. Depends on what type of lip you have, of course. And here you see the hockey stick in the lower lip much better. You see that? So this is how the muscle goes. And actually, when you put your botulinum toxin in here, you paralyze this area, and this makes you flip your lip a little bit because you inhibit the downwards pull of this part peripheраlis of the orbicularis oris muscle. And here you see the artery being well below the point of injection, but this one, well, is quite close. It's not the main artery probably, so probably fine, but be aware. Beautiful image, I would say. And then here, there's the superficial one. Okay. I was asked to say a little bit about the neck, and of course the neck we sometimes do inject that to get rid of the volume of the submandibular glands, as is somewhere around here. This also is a beautiful picture. It's way down towards the dorsum of your head. Not so much in here. Sometimes people think that, but it's somewhere around here. And have a look with ultrasound. There has been this study done by Yi with the outer part of your eye. When you go down, it's like 2 centimeters below the edge here. That's the point to inject. Now, I did something similar with the Clarius, just to identify the gland, which, of course, if you really know where it is, it's easier to inject, and it's more safe also. Because have a look, it's not so simple as it seems from this article by G. So what you do first is, of course, this is the masseter muscle, this is an artery, and then you slide downwards, right? So then you come by the edge of your jawline, of your mandible, and then when you go over there, you always see this kind of structure. This is the platysma. This is subcutaneous fat. This is, of course, dermis, epidermis, subcutaneous fat, and then there's the platysma. But here you see some structures that might interfere with your injections, right? Then when you go down, you're going to see this homogeneous hyperechoic area, which looks much like the parotid glands. And this is indeed the submandibular glands. But have a look here. Those are a little bit frightening to me. So I put on the color box, and I see that those are very large vessels. So not a safe area to inject. Well, maybe if you come from here, but it's not something I would recommend. So then when I go a little bit further, I can see with the color box on that there are no arteries anymore in this gland I'm going to inject into, right? So again, skin, dermis, subcutaneous fat, and the platysma muscle. Now, there are several structures there. Most of them are muscles. They run in various directions, and then there are the large arteries and veins. And if you have a look there, it's very easy to identify this one, which is the sternocleidomastoideus muscle. This is another more rounded muscle in the lower part of the chin. Easy to identify, not something to inject into. If you inject, always in the platysma, or if you want to do, of course, the submandibular glands, as I told you. Now, integrating ultrasonography in your practice, and I would like to have a comment from Dr. Roy in a minute. So what we do is that the course of arteries are varying, so we would like to see that and not go from textbooks on, because they're different in every patient. Identify prior fillers. I'm going to show you a little some of them. Evaluate complications, and people come in with complications. That's much easier to have an ultrasound and tell your patients what's happening down there than if you have to guess. And then these are the basic ones, I would say. And then once you're more advanced, you can also have a look whether the placement of filler is correct, which gives you a better outcome, of course, especially when you do it during treatment. Many doctors are a little bit reluctant against that because it's something that takes more time, which indeed is. But that is important for your career, for the quality of your working. So I would recommend doing that. at some point when you're at least more advanced with the use of ultrasound. So you will have a better outcome, that's for sure. Because less bruising, we published an article on that, less complications, and more effectiveness, more efficacy. And well, I think you have to be careful with this a little bit, because if you only get complications, which you cannot charge so much for, you will lose your normal practice. And I've seen that happening for instance, in Germany. Mauricio Serron is somebody who gets all the patients more or less with severe complication from Germany, and well, it's become too much, so it might be counter-effective. And then for marketing, and that's the big profit, I would say, the safety. People call us up in the Netherlands, or well, not only us, but all the other practices, to ask for ultrasound. If we're not using ultrasound, you're not eligible for those patients anymore. They don't come to you. So it's a big marketing strategy to use ultrasound. Unfortunately, many doctors say they have ultrasound, and they do have an ultrasound, but they don't use it. So that's another thing. And then you don't have the better outcome, and you cannot treat your complications, and etc. Okay, this is the little article I was talking about. We published with one of my PhD students, and the basic thing is there is a bruising score, number 6, no bruising, in the intervention group. So the group that was scanned before, there was no bruising in 70%, 70, whereas in the control group, ones that were not scanned before, it was only something like 30%. So it's a real difference, significant, etc. So this is the first time it's been proven that it really helps, and we can take this, I think, as a proxy for intravascular injections and necrosis and vascular obstructions, right? Because it's the same thing, more or less. You open up an artery, and then, well, of course, you may inject and obstruct the flow. This is how hyaluronic acid looks like. It's black because it's a gel, of course. This is what calcium hydroxyapatite looks like. It's hyperechoic because it contains structures that will reflect the images. And this is silicone oil. And silicone oil gives you something which we call snowstorm, and then there is some posterior shadowing afterward. And I love this picture because you can imagine what's happened here, right? So this person was injected with a liquid silicone because there were, after botulinum toxin, still some lines left, and they filled up those lines, and that's why it's those 2 cracks that's down there. Again, hyaluronic acids. Again, hyaluronic acids. Now in the Swift point, and the good thing to understand here is that this is the muscle, and if you inject in here, there's no space for a pocket to build up. So you will get some spreads between layers of muscle, and that's good to know, I think. This is silicone oil again, but now in the upper lip. Here's a little bit of normal tissue, and this is all the snowstorm pattern. And you understand that there is tissue here, but you cannot see it because everything is reflected. Some words about the correct placement during injection. I hope you recognize the masseter muscle, the parotid glands, and the subcutaneous space here. And this is frequently misjudged as HA pocket, but especially in the parotid glands, you will have lymph nodes. So this is a lymph node. And you see the distance here. Actually, you should look at the distance here, which is 0.225. This is the subcutaneous space you want to inject into when you do pre-irregular injections, for instance, with biostimulating fillers. And well, we have seen this case of a lady that came in with this after being injected 6 months ago, but then she catched COVID, and then this started. And as you can see, there's HA all along. This is actually connected with each other, and that tries to come out. But the thing is that on the other side, we saw this, which is the same thing, but it does not come out. So it doesn't give any complications, but it's still there. And it's, well, I don't know, it's a big deal. It may not interfere with the normal function of the parotid gland, but it is indeed not working as it should be as a filler, right? Or a biostimulating substance, because there's not much fibrous tissue to stimulate. So I think you should be aware of that, and it's quite easy to, well, if you insert your needle to just to check whether you are in the correct layer. So this is a matter of assessment of filler placement during injection. You can see the whole tract, but just look at the placement. If it's correct, is good enough at first. And have a look here. This is a video, and I hope you recognize this black structure, which is a muscle, the DAO muscle, seen from in a longitudinal fashion from the corner of the mouth to the corner of the edge of the maxilla. And you see here the cannula coming in. And what you see what's happening, right? It's going inside the muscle. And is that painful? Probably a little bit, but not so much that the patient doesn't tolerate this. But here you are in the wrong plane, right? And there is not much space here. You can appreciate that as well, right? So these instances, I think, this is an area, this is the Marianne line. So this is the area you're injecting quite a lot. Okay, so a few words about the technique of using ultrasound-guided injections. This is called the in-plane technique. And I'm going through this a little bit quickly because of time, etc. But I understand that this is being recorded, so you can look it back. And the thing is that when you do the in-plane technique, which is actually, you're going to see the whole needle coming from one side, and then you can adjust much easier than the other technique. But have a look. So you're in one line. Please look at this later. And this is what you can see. This is the needle or cannula coming in. And this is, for instance, this is a pocket of HA you want to dissolve. And you see the whole line, the whole tract of the cannula. Whereas this is the out-of-plane technique, meaning that you come from one side and you're only going to see the tip of the needle once it comes in. So you proceed putting it deeper and deeper, very slowly, and at some point you see it's something bright coming up. It's like this, right? You're supposed to be like 0.5 centimeter or 1 centimeter away, because that's the only way you can adjust your angle a little bit to get at the right position. And this is your angle, about 30, 45 degrees. Okay. So please read this later, but have a look. So this is what you're going to see. This white dot that comes in, this is what we call the out-of-plane technique. But if you go further, if you don't stop with proceeding with the needle once you've seen this this white dot, you will stay seeing this white dot, but then you are looking at not at the tip but at the shaft. So if you really want to know where you are injecting, you should stop, because otherwise you're passing this point that you want to inject into. I hope I make myself clear with this, because it's an important part to understand. Some words about vascular occlusion. This is a vascular problem, right? It's a vascular adverse event. You see bruising, and you see this what we call the vado reticularis in dermatology. It's this marbling type of pattern, which is in our conception a type of spasm that is that's been provoked by this injection. And also on the inside of the mouth, this frequently happens. Now have a look here. This is the ultrasound image, not a premium machine, just a regular machine. Not even a Clarius would have given you a better view, actually. But what you see here are collaterals. Those are arteries that try to get oxygen into this area, which is very what we call hypovascular. So it lacks vascularity, and it is probably a bruise in combination with the HA filler. Okay, well, let's have a look. So what we do is we're going to release this, of course, with hyaluronidase, it comes in from the right. Now it comes in. You see some moving artifacts. Here it comes, right? And we come into the pocket, and then we release our hyaluronidase, and then we have restore flow. Those are 3 videos, one put behind the other, right? So have a look again, because it tells you here on the upper right side the time frame. And the time frame, it says it's, I cannot see it, it says 1655, I think. And now it's 1708 or something. So now we're going to inject the hyaluronidase. And then 1711, so 3 minutes later, it's restored flow. And this is how it goes. It goes very, very quick if you identify the right spot. Now, I know there are other patterns of injection or other protocols for injection in which you do flood the whole area. But we've been very successful with this protocol, which is always aimed at the area where the bruise is, because that's where the artery is being opened, right? Otherwise, you would not have a bruise. And then we try to identify the area with the least. This is a different. Oh, well, this is another video. We try to identify the area where there is reduced flow. And here is the upper lip. You can see here it's an artery pulsating, but this area is more or less devoid. Here it is. This area is more or less no vascularity, and it's also blackish and egoic, hypoegoic. That's exactly where the filler is. So this is on the right side. This is on the other side, and you can see here there's a lot of vascularity down there. So this is how it's supposed to look on the other side, but it does not. And then we inject with our hyaluronidase, and then you see in a minute the flow coming back. So you see that, right? So this is more or less restored flow. It's not like it's on the other side, but this is very, very definitely good flow. Now the protocol that we use is it's on our website, the cutaneous website, and the only thing you have to know is that it's you should inject under ultrasound guidance at the deepest level of the superficial fatty layer. And why is that? Because we think that is the area where the perforators, and that's how the plastic surgeons call those arteries that go from the main artery and go upwards to the skin. So, and that's where the perforators leave the main artery, and that's also where the spasm is probably taking place. So, if you release the spasm there, if you release the contact of the filler with the endothelium, you will have a restored flow in a few minutes. And this is actually not confined to HA. It's also the thing with calcium hydroxyapatite. Now, I think I do have some time, and I do have a little extra, if you don't mind, guys. So, small extra, okay? Because this is our newest research. We try to identify how the different substances spread to the tissue. And one of the things we published about is the backwards flow. This has been published, I think, 2 years ago. You can see here a video with a cannula coming in there, touching the bone more or less. But you can see that, well, I always thought when you push, the material will go forward as well, but actually it goes backwards. And it goes backwards along the shaft of the cannula or the needle, and that is because it's the way of the least resistance, right? It's the place where well, if the pressure builds up, the material is bound to flow to. So that's one thing to know. This is another video with backwards flow. You see the cannula. You see it's going around here, right? I think it's amazing that we never thought about it. I'm doing this for 30 years, and I always thought it would go like forwards or put in like a big pocket or something, but it does not. Let me show you this, which is the calcium hydroxyapatite. Hyperegoic. What I learned from this is that I always thought I was making a tunnel and I was filling up this tunnel. But it's much more than that. It spreads much wider than just this tunnel, and it's I never thought about it actually. Well, it's you would think that it's we would have figured it out already, but we did not. And one of the important things to notice here is that it stays between those layers of fascia. Of course, you do have the SMAS here, but you have also in the subcutaneous space you have fascia blades or membranes or whatever. And if you between those membranes, those membranes they seem to catch the filler there. PLLA is much more liquid. So what you see is happening here is that it falls downwards. You can see that, right? It falls downwards. And it also fills much more space than I would have thought of at the beginning. You see it, right? Going out, falling down, and filling up the whole space. Actually, we've done some follow-up studies on this, and we found out that it takes about a year to dissolve this material. It becomes thinner and thinner all the time, of course, and it seems to concentrate even after 1 year on the lower side of the dermis, which makes sense because in the lower side of the dermis, the most fibroblasts are there. And it's not only for the PLA, it's also for the calcium hydroxyapatite and the harmonica, the combination of those materials, that it starts to be confined to these what we call retinacula, these areas here, the fascia and the lower part of the dermis, and there they seem to stimulate. There's something happening there, and that's probably the stimulation, the effect of these materials. Because in the fat itself, it does not do much, right? It's supposed to stimulate it. And have a look here at the buttocks. Many people do that. And just to point out a few of the landmarks here, this is the muscle, the gluteus maximus. This is what you could say the SMAS, the most important fascia, and this is the subcutis, and there are several fascial layers. And have a look. You see, here's the material coming out, PLLA, and it's confined between those layers, so it cannot pass through those layers. That's the main message here, meaning that if you want to fill everything, so the whole subcutaneous space, you need to place your cannula in those different layers. So this is in the middle layer, so to say, and now we are in the more superficial layer, right? You see how that works, right? So I think, well, it's of course very obvious to do this type of work to see where it goes, but it tells you quite a lot, and it's a little bit of a shame that we didn't do that more previously, because now we know what to do if we want to get the full effect of these things. Okay, so this is basically it. Thanks again. I did speak a little bit swift because I always get excited and I want to convey so much information. I hope you catch it. Again, I understand that it's being recorded and you can look it back. So it's I hope this helps. Okay,
Thank you very much, Peter, for a wonderful lecture.
Thank you.
So, I think that this lecture shows us the importance of ultrasound in our practice, right? We can use it like before, during, or even after the procedure. So once you start using it, you cannot stop using it. You have to use it every day. So We have lots of questions in the box right now. So, oh, I see that there are so many questions. And let's start with the first one. I'm going to pin this question. Since you mentioned about the backflow of the material that we inject, there is a question asking about, I'm interested in the backflow video that you just showed. Can you mention which area that has high resistance so backflow often happen?
Yes. Well, the thing is, our research has moved on, of course, and what we found out is that it's not only backflow that you see sometimes forwards flow. It depends more or less on the area you're in. This was done on the lateral side of the zygoma. Well, if you go more medial and you go on the lower part of the zygoma, you're entering the deep medial fat band, deep medial cheek fat bed, and that is something that you can take to your advantage actually. If you are more on the superficial part of the zygoma, you're bound to get into the temples, and we have also made a publication about that. And we found out that this happens after you've done more than 0.2, 0.1, 0.2, depending on how much space there is. It's bound to go into the temples. And that may not be bad actually, because you get a much more smooth transition from the zygoma to the temple. But those are effects that we need to sort out for all the areas in the face, I think. But it's it's something to be aware of. That's the main message now. But it's going to change our way of working. Raya, if you have any comment on that?
I can add something, just mention something, because in some area, the shape of this mass at retinaculum cutis is totally different. Based on the depth that you place your filler, based on the rheology of the filler, you get more backflow or, just anterograde flow. And then sometimes that's why we get more migration in some area than the other area. For example, in infraorbital area, as Peter beautifully mentioned, in lateral part of the zygoma and the temple, based on the shape of this, and then we know based on the rheology, filler goes, like in a resistant area that we can just easily observe with the ultrasound.
That's right. Yeah, so let's move to the next question. There's a question about, is it possible to identify false ligament, for instance, mesenteric cutaneous ligament with ultrasound machine?
Say again, which ligament are you talking about? The mandibular?
Mesenteric cutaneous ligaments.
Retaining ligament, I believe they meant just some like partido-mesenteric fascia or just retaining ligament. Mostly, yeah, that's the same thing. Yeah. Go ahead, please, Peter.
Well, I can say a little bit about ligaments, if you don't mind, because what we are actually studying ligaments, and what we found is that the connection between the bone or the periost and the SMAS, that part of the ligament is very tight, actually, and that doesn't loosen up very much when you grow older. But the superficial part coming from the SMAS to the skin, those are the ones that become looser or sometimes are simply lost. So it's yeah.
How about the nerve, facial nerve or trigeminal nerve? Can you identify with the portable L20 Clarius machine?
Well, I'm not so much into nerves, I must confess. The thing is that even with the more premium machines, I cannot find the nerves very well. There are some machines that claim to be able to highlight those, but I've not been able to do that. Dr. Ryan?
I'm kind of the same, but mostly I find the nerve close to the foramen. Usually I find, like supraorbital nerve, mental nerve, infraorbital, that one, and sometimes, like just auricular nerve, but not all the nerves. That's why, like we're just because or surgeon usually do that, but definitely they can find it with L20, because sometimes even I find the frontal branch of facial nerve as well. if they practice more, and then they can find the nerves as well.
Yeah, sometimes it's very small. Yeah, difficult to find. So the next question is, can you share simple tips and tricks to identify foreign body like HA, which is dark, which is black, but located inside the muscle, which is also black? How can you make a difference?
Yeah, for me, I don't know about you, Roy, but it's the amount of echogenicity. Mostly, you see the muscles have some fibers inside, right? And then it's so those are longitudinal. If you do it right, you have to rotate your device, of course, and then you see something very, very anechoic, and that's that difference that gives it away. That is for me. Also, then when you follow that, it's like a smooth line, and then something bulges out a little bit. That's where you probably have the filler. But it's all a matter of interpretation. You never are completely sure.
Yeah.
Yeah, exactly. Sometimes, like for the muscle, you need to just ask the patient to, like just a little bit animate the area that you can, the bulging of the muscle. And the other things you can do, change the gain. If you change the gain and increase the gain to the, like the maximum one, mostly because of the fibers that Peter said, because of the fibers, it's become hyperechoic. But the anechoic hyaluronic acid stays, it's become a little bit smaller, looks smaller, but definitely it stays anechoic.
Yeah. And how about the calcium hydroxyapatite, which is white, but sometimes located too superficial in the dermis, which is also white? How can you compare the difference between these two white structures?
Yeah,
posterior shadow.
Posterior shadow. Yeah, yeah.
Sorry.
Well, posterior shadowing.
That's
you're quite right. The L20 will help you with that, but there are many of those machines that are have a lower frequency, and then you don't have any posterior shadowing. So it depends on the frequency of your device. So that gives it away in a way, but it's I frequently have the difficulty deciding which part is indeed the dermis and which part where the calcium hydroxyapatite starts. You sometimes don't see the transition, but it's a very good question, and I struggle with that as well. But you do see, of course, the calcium hydroxyapatite. It's more particulated, and it has a different structure, but it both is hyperechoic. That's completely true. Yeah.
Yeah, but it depends on the, like using the calcium hydroxyapatite, the main one, like the concentrate or diluted or hyperdiluted. Mostly for diluted and hyperdiluted, as Peter shows on the videos, is like cloudy. Usually you don't see that posterior shadow and everything. For the lower dermis as well, you don't see not every hyperechoic structure makes shadowing. It's a bone usually and calcium, or like even gas, air and gas. They are just making shadow. But sometimes if there is a calcium hydroxyapatite, the concentrate one, you are seeing, because it's blocking sound waves, that's why you see the shadowing. But it's still, like hyperechoic in hyperechoic is just a little bit, not so difficult, but not easy.
Yeah. Sometimes you have to like scan it more often, and you will get used to it. Yeah.
Exactly.
And how about there's a question asking about the hand probe is quite wide. Can we see columella, because the columella is sometimes quite difficult to contact, right? So I think maybe we just put lots of gel here, because
yes,
like
exactly.
yeah.
Because face is like the face is just contain of hills and valleys. Every valleys you need to fill it up with the gel. That's why like this acoustic standoff helps you to see the whole layers without pressing.
Yeah, that's right.
Yeah, exactly.
But make sure your patient's breathing from the mouth, and then you put the gel.
Yeah. Otherwise, you will suffocate the patient.
Yeah, it's a bit of a messy business, is all this ultrasound, and you don't go short on gel. make sure you always have enough shell with you. That yeah.
Yes, exactly.
It
The
ruins your
next
makeup also. It's it's always a mess. I tell my patients. Yeah.
How about the neck? How the attendees ask about the neck. How can we differ between subcutaneous fat and platysma? They seems a little bit black and very thin and very close structure.
Yeah, there's not much subcutaneous fat most of the time. And it looks a little bit like the platysma, but it's very, very well to distinguish that, because it's those are two straight lines. It's like a train track. It's two white lines with something black in between, and you cannot miss it actually. It's so very easy. Whereas the subcutaneous space is mainly black. It's thicker, and it also has those waving type of sheets in it. And whereas the platysma is completely straight, and it's actually not to be missed. Any comments on that, Roya? What do you think?
No. That's totally, like correct. But just, train your eyes to see the different shades of gray. That's all. Like the echogenicity of the fat, especially subcutaneous fat, is totally different than muscles, because, like you're looking for something that you already know. That is epidermis, upper dermis, lower dermis, subcutaneous fat, and now platysma or in the faces mass. That's why, different echogenicity, different shades of gray. But I agree, mostly even for people that have double chin, either is mostly because of the laxity of the muscle of the flora mouth, not because of the thick subcutaneous fat. In neck area, subcutaneous, as Peter said, is very thin, but different echogenicity, that thin hypoechoic muscle.
Yeah, that's very blackish. Yeah, that's true. That's true. It's a good point, fair point.
Okay, the next question is about the toxin injection. For depressor anguli oris or DAO, do you usually do ultrasound guided or just only the marking?
What do you do, Roya?
I do ultrasound guided. I do ultrasound guided. I scan first, because most of the time we are scared of get, like complications here to just leaking to the DLI. That's why we're not going properly inside the bulkiest part of the muscle. That's why we miss the muscle. We don't see the result. Most of the time, I go from the posterior in plane mode and then get into the bulkiest part, just very small amount, maybe 2-3 standard units, and that's all. I make sure that I get the bulk, I see the result, and no complications. For these two muscles, I always do. For masseter, for bruxism, and for DAO.
And which thickness of needle do you use then?
What is the needle? No, I usually use 29, the gauge. 29, I can easily see it, like the resolution is so good, even without needle enhancement, 29 and 38, but mostly you need at least 25 millimeter length. You need the just, bigger length. Yeah.
Yeah. Maybe I can say a little bit about this, because we are struggling with this, because we think if you do it correctly and you go inside the muscle fibers, you probably need less material, right? That's what you're doing, Raya. And yeah, that's what I think. So, but it's not been proven. So I struggle a little bit to do that, but I do, and I have good effects. So I reduce my number of units by 50%. I do half of it, and then and I'm teaching a lot. And so my students, I always try to teach them to do this ultrasound guided. And they are amazed, because they used to do it in a loose hand way, and they're either much too deep or not so super. Most of them were too deep, and sometimes even outside the DAO or very close to the DLI. And it freaks them out actually when they see what they've been doing. So it's really something that's been very helpful for us in our practice. Yeah.
Especially is amazing because DAO is like a fan shape, and then if you're going toward the lips, you see the bulky, of modulus hypoecho, and if you come inferior lid, you see very flat. That's why
Right.
we can just precise which area, which is the midway of, commissure and the mandible. That's the bulkiest part that you can get it just posterior to the marionette line.
Yeah.
With
Yeah, if you
the
go
ultrasound, you can locate it.
If you
The
go
result is very good.
sorry, if you go too low, it's such a thin muscle, and it's so the bulky areas is much more over here. So I also have many doctors that start always here, or are used to do it here, but then move upwards, because that's exactly the point you should be.
Yeah, totally agree. My patient loved the result very much since I use ultrasound guided injection for DAO. They say that they have the biggest smile since they have been injected with the ultrasound guide technique.
Yeah,
That's
that's
good.
good, and that should be. Yeah, I can imagine that.
Let's move to the next question. They ask about for vascular occlusion complication, how can ultrasound help in this situation? I think we mentioned about that in Dr. Peter's lecture for some, but we can discuss more if you want to.
Oh yes, let's. Do you see a lot of problems with that, Raya? Or
Yes. I'm getting more people, like referral from all the doctors. That's why we're just doing, ultrasound guided, not now hyaluronidase. And definitely I'm following the protocol from cutaneous, which I'm going, like over this mass, deep subcutaneous area. I start from, like close to the hyperdilated area and dermal vasculature that I see, because when the perforator damaged or occluded, you see the silent area, as Peter, beautifully explained, and then you see just the linking and the lipid dermal perfusion to come to help. That's why I'm going, like to the silent area over the SMAS, start from that area mostly. Even it helps with the resolving shock phenomenon and spasm. If you go, like start from exactly, because perforator comes from SMAS over the SMAS and gives all the, way up. That's why I usually do under the guide using less amount of enzyme, hyaluronidase. And, like I can see the flow. That's why.
yeah, maybe I can elaborate a little bit, because well, we developed this protocol. We are quite successful with this. It's like 5% of all the patients that come in, and we've done over 200 now in our country. So I think 5% need to redo after 1 day or so. But the thing is, what we get a lot of requests from outside of the Netherlands, outside of our country, to help doctors doing this. So like a telemedicine or something, virtual medicine. And we've done 39 now. And we, with all kinds of machines, with all kinds of experience, and only 4%, I think, like only 2 of those cases, it didn't work out. So you can guide patients or doctors on a distance, but also they don't have to be experienced very much to do this. If they just know where to look for and where to go with their hyaluronidase, it's quite easy to do this. So, well, I think this is, but you need an ultrasound for this, because you need to identify the area where the flow is has gone down, and of course you can also see where the SMAS is. It makes it also easier, because you have to be, well, just a little bit above the SMAS. But yeah, I think it's a great protocol, and it saves people's skin. And actually, you can do it even after 1 or 2 weeks. Not that it saves then the skin, but we have some patients that had pain for a long time, and they were relieved after, for instance, 2 weeks after the initial injection, and got rid of their pain. Yeah,
that's good. Actually, Dr. Natachat he's pro, because he's he's working in a complication center in Bangkok.
Yeah.
That's why, like he's seeing a lot, he's treating a lot. I know that he's expert in this. Maybe you can add
please
comments.
tell us. Please tell us. Yeah.
Yeah, please.
Because Since our center use ultrasound more, we have lots of case like flushing from all over Thailand or flew from by the plane from other province to our hospital. So we have lots of vascular occlusion cases. And I would like to say that ultrasound, since we use ultrasound, we use less and less amount of enzyme to treat this problem. I think it's very good because when you use ultrasound, you see what happens underneath that problem area, and you use ultrasound guided, inject enzyme into that specific area, and you can see the result afterwards. And one more thing that I see lots of case right now is the nodules from after injection. Every material, both HA, biostimulators, I think it's not the problem of the product. I think it's the injection technique or maybe dilution. Because when we scan it, you see lots of different clumps of material, maybe into the wrong plane. That's what I see more frequently, like inject into the parotid gland or maybe into the masseter. So when the patient come to you, if you have ultrasound in your practice, you can scan the problem and you can help the patient. You can do ultrasound guide correction. You can use mechanical disruption by insert cannula inside the biostimulator material. This is what we quite see more often right now. Yeah.
Yeah.
So I say that it is very helpful. You should try and start practicing. Yeah.
Amazing.
Yeah, of course. Well, we have a complication clinic in the Netherlands, as I said, for more than 11 years now. And it seems to be so that when we look at our numbers, the type of complications that we see, our conclusion is that over 50%, maybe even 75% of all the complications are bad technique, are doctor made. So it's something that's yeah, and well, especially for vascular occlusions, of course, it tells you that if you scan beforehand, your chances of getting that will go down tremendously. So it's definitely something you should use, I think.
That's right. Yeah.
Okay.
Okay. One question, add more about the complications. Some injectors find it hard to distinguish between bruise from livedo reticularis. Can we check this with ultrasound? Between bruising and
Yeah.
livedo from occlusion.
Yeah, that's a difficult point. That's one of the main focus point of our research now, because the thing is that we only have our eyes to distinguish, right? There's no objective measurements that we can do to well, of course you can do arteriography or something, but that's not feasible. That's something that takes hours to organize, etc. So it's no, you really have to use your eyes to see if it's a vascular occlusion. So it's a clinical diagnosis. We try to measure like flow patterns around these areas to see if that could help. And you can also do the pulse wave with the Clarius, of course, which is a great feature, I think. But we don't have the numbers to tell you whether this is something that is helpful. So, well, yeah, you have to identify and you have to develop your eye for that and see if it fits your. I think there's always a bruise, but everything that looks a little bit suspicious around it, and it's always more cranial, right? So it's the bruise and then something on top of that. And actually, we published an article about the different patterns that can be seen after vascular occlusion, and in each area they have the same shape also. And if you should download it. It's free access. It's from the Journal of the American Academy of Dermatology at the beginning of this year, I think. And you can see how that works, how those patterns look like. And if it's something similar, so it's the bruise, and then in conjunction with that, some redness, and well, that's similar to what you see in those in this article, then it's most probably a vascular occlusion. I must say one more thing, and that is that the vascular occlusions by HA, they look quite a lot like I've shown, but the vascular occlusions coming from calcium hydroxyapatite may look different. They're more reddish. They're much more inflamed in the area outside of the bruise. So that may be a different pattern. The pattern is the same, the form of the pattern, but it might not be so the fadeoid, so to say.
So the next question is, can we use ultrasound to measure skin thickness after inject collagen biostimulator, and we can see the change of the thickness of the dermis?
Well, you have a distinct opinion about that, Roya, I think, right?
Yes, exactly. But what we need to know that all the measurement, especially on the surface, like most superficial part of the skin, you need to do it with a lot of gel, ultrasound gel. No pressure, zero pressure, then you can just rely on your measurement. And always you need to just do the landmark, mark the area that you are doing the treatment. Just do the measurement before the treatment and after the treatment, then you can do it. Some of the software that there is, there are some software that they can make it, like quantify, not just qualify, but definitely if you use the zero pressure, the measurement is right. And if you use the specific preset, then echogenicity even help you to see the treatment outcomes. If lower like lower dermis, reticular dermis is become hyperechoic, more hyperechoic, and then change in differentiation between this layer, you can tell that your treatment, anti-aging treatment was, like effective.
Yeah.
There is some tips and tricks to do it, but definitely you can do it. Yeah.
Yeah. Yeah, I have nothing to add to that. I was just introduced yesterday by Dr. Roya for the volume measurement function on the L20, and I love it. I think it's amazing extra that you get with this machine. Yeah.
Yeah. So, Dr. Maria, the attendees asked about the length of the 20G needle that you use for DAO injection for toxin. What is the length?
Yeah, I mostly use 2-inch.
2-inch?
Sometimes,
Okay.
like 1-inch or 2-inch or 1.5-inch, but definitely more than 1-inch, because otherwise it's not. Usually you have to either use the sterile ultrasound gel,
Yeah.
or use the sterile cover. With the sterile cover, then you have to put the gel on top of your footprint and then cover with the sterile cover. And then you can just use the povidone or a spray of alcohol on top of the cover, because you need everything, disinfected, and then a hygienic area it has to be. But definitely you need longer needle, not with the short needle, like 13 millimeter. No, it's hard to see it below.
Yeah, I need to say a little bit about that, because I know there are doctors who do the out-of-plane technique, and they are able to use shorter needles. But I don't like that technique. I like the inline technique, in-plane technique.
Wait. Yes.
Yeah.
So, but then there are some doctors that do it differently.
Yeah, I think
Coming
for
from
beginners, plane injection is easier, I think. Yeah.
Mhm.
So, Dr. Ria, about the masseter injection, the audience asks about why do you also perform for masseter under ultrasound guidance? The muscle is quite big. They ask about it.
Yes. Yes. I usually use the longer needle, first of all, like maybe 2-inch. And then my approach is from the posterior part, because most of the masseter muscle in different ethnicity, they have 3 heads. One is posterior deep, one is anterior intermediate, and one on top, which is superficial. That's why from, like the posterior part, I'm going directly inside the muscle. First, I get the intermediate part, the post anterior one, and then I'm back in the deep posterior one, and then change the angle to go to the superficial head. That's why from one point I can target 3 heads.
Oh, okay.
You can
Maybe I
do
can
something else, but is not as precise as in plane. Okay, you can go on top of the muscle and ask, like your patient to clench, then bring the midline marker on top each head and mark it from the surface, and measure the depth of the bulkiest part, and then you go without the ultrasound, then you can go either pre-treatment assessment or ultrasound guided, which I prefer ultrasound guided. I want to see the needle.
Maybe
That's
I can add a little bit because you know, once you have injected the toxin in the muscle, you see it's very white. And you can also assess by this if you have catched all the different values of the muscle. So I do it more or less like Raya said, but it's there might be a different option that's in this way. Yeah.
Okay, let's move to our last question for today's webinar. The audience asks about, is the enzyme enough for a single session to treat delay onset nodule after HA filler, or do we need multiple sessions?
So you're asking about complications after late onset, and if you need more than one session. Yeah, that's very difficult to say actually. The thing is that we found out that it's if you do, for instance, HA with hyaluronidase, it's not so easy to dissolve that. It depends on the type of cross-linking, of course, also the concentration of the hyaluronidase. But the most important thing is that you have to be really inside this pocket of hyaluronic acid, because otherwise, when it's somewhere around it, it doesn't mingle. The diffusion, you could count on diffusion, but it doesn't work that way. You should really be inside. And when it's a large pocket, you need to go at several areas inside actually, because also with a large pocket, you will not have the diffusion in all the areas of the filler. And then I think you should also inject a little bit forcefully with force, because then you mix it much better. That's important. And I think you should massage afterwards, and then that, of course, you should do a little bit gentle. But in my practice with the late onset reactions, I almost always see them back, and it's not a one-time treatment. Unfortunately, but if you take the time for it and you do everything under guidance and you do all the little pockets, etc., then probably you might experience like a good effect in one treatment.
Yeah. Okay, so we have lots of questions today. So this is the end of our webinar today. That brings to the conclusion of our webinar today. So I would like to ask both of you to give one big tip for beginners or everything that use ultrasound already. What tips do you want to give to the audience?
Well, of course, it's with ultrasound, it is pattern recognition, right? As we said, like if you want to see the difference between the platysma and the subcutaneous fat, it's just in the pattern. And the only way to develop that is practice. So if you have done a course or you learned a little bit from somebody else or whatever, you should practice. You can practice on yourself actually. So it's very easy, but practice. That's the main thing to get better in it. Yeah, that's my tip.
Yeah. How about you, Roya?
My tip is kind of the same. Practice makes perfect. Every day, constantly, zero pressure on virgin face. Like try to do the scanning on the people that never done anything to see the, like untouched structures. That's why if you see something that's not supposed to be there, then you easily can recognize. Practice.
Practice, yes. One more tip to add. I think that one main problem for a beginner is that sometimes when they scan, they don't know what is this. So if you are a beginner, you need to correlate with the anatomical knowledge that you already know. Try to look at the textbook, the image that you see from the textbook, try to scan it the same way. So that way you can correlate with the normal anatomy and always practice.
Exactly.
That's a very good tip. Yeah, there are lots of books out there and articles, so that may help. Yeah, indeed.
Okay, so this is a very fruitful session today. We learned a lot from all the panels. Okay, so if you have any comments or any question, you can ask, and maybe we can answer it later. So thank you very much, Dr. Peter and Dr. Royal, for sharing wonderful tips and sharing your very good lecture today. So thank you very much. See you next time.
Thank you for having me. Thank you so much. It's an
Thank
honor.
you.
It
It's
was
an
an
honor
honor for
too.
me as well. It was very nice.
Thank you.
Okay, bye-bye, guys.
Bye-bye.
Have a good night.